So today we will be talking about back pain and what to do if someone comes into the office with just a complaint of back pain. The first thing we need to know is that we can classify the time period that the back pain occurs. Less than 6 weeks, 6 to 12 weeks, or more than 12 weeks. And this does change the management of how we treat the back pain. So right off the bat, there's a few things we need to worry about. There's some etiologies that we want to rule out that are very serious. So let me give you the basis of the first one called Cauda Equina. Cauda Equina is when you have compression of your spinal nerve in some way that causes really bad emergency level deficits. So what can happen is you have your spinal cord here and your vertebral disc. The nucleus pulposus, when it's put under stress, when you bend a bad way, you pull something twisting your back, can actually herniate and impinge the nerve root of your spinal cord. This can also happen through chronic processes called thickened ligamentum flavum or hypertrophied facet of your vertebral bone, which you can see in osteoarthritis, but we will get to that. So, with Cauda Equina syndrome, your Cauda Equina is the lower half of your spinal cord, and if this gets compressed, you can have really serious deficits. As you know, spinal cord, the nerves come off of this, or like your sciatic nerve and things like that, as well as nerves that go to your bladder. So you will have loss of deep tendon reflexes, you will have numbness and tingling of your lower feet and weakness. And one thing that you want to be concerned about is the saddle anesthesia. The reason it's called saddle anesthesia is that you can think of riding a horse, a saddle, wherever it goes, you can cause anesthesia. So the constellation of all these symptoms are emergency level, and the patient needs to be referred to the emergency department immediately. The other thing you want to be concerned about is metastatic cancer. On an X-ray, you look at the bones, and you can see these, metastatic diseases in your spinal cord. And you want to think about this: if someone has a history of cancer, they're likely to present with back pain that is consistent with bony metastasis. Similarly, if they have an abscess or osteomyelitis going on, this is an infectious picture. And this means that in their spinal cord or maybe their bone, they have some sort of infection like Staph aureus. This usually presents with fevers. The other aspect that's acute is vertebral compression fractures. So it is what it says, your vertebra is compressed. And this usually happens in elderly people who have osteoporosis, postmenopausal, osteopenia, they're not taking their vitamin D and calcium. Essentially, they get a fracture by some injury or just, getting old. And that's actually one of the very huge risk factors is elderly age and being on chronic steroid use. The things to consider about this is that a person who may not be old but on steroid use may have, immunological disorders, autoimmune disorders, and they're talking chronic prednisone, and that's why they may have weaker bones. The other thing to think about are less acute things, but things that you will deal with on a daily basis. So radiculopathy, this is like Cauda Equina, but less worrisome. It's the same idea that you're going to have impingement of a nerve root, whether it's through herniation or whether it's through inflammation of some aspect. So you can see here that the herniated disc is affecting the sciatic nerve here. And the cool thing about this is based on the level of the herniation and the nerve impingement, you can kind of localize where it actually is based on the constellation of symptoms. Say, for instance, you have an impingement of your L4 nerve root. You're going to have pain along the lateral aspect of your knee, leg, and then you're going to have problems extending your leg because you're going to have numbness on the quadricep muscle. Likewise, if you have more of a sciatica-like picture, an impingement of your L5 and S1, you're going to have pain radiating down the back of your leg and inability to plantarflex or dorsiflex your leg. Now, what we want to also talk about is spinal stenosis, which occurs mostly in elderly people. The pathophysiology to remember is as you get older, things get calcified, things get rigid, and one of those things is the ligamentum flavum. The ligamentum flavum is this band-like material that runs posterior or anterior to your spinal cord. And usually, if the band gets very thickened, it can cause some compression of your spinal cord. That's going to cause you pain. The one thing to remember is something called the shopping cart sign. What this means is that the patient is going to bend forward to straighten their spine, kind of like they're pushing a shopping cart, and this is going to alleviate the pain. The reason for this is that basically when you have a thickened ligamentum flavum, it's causing compression at these areas. So if you bend straight like that, you actually open up your spaces and you alleviate the back pain, particularly in elderly people. So other etiologies to consider are ankylosing spondylitis, osteoarthritis, scoliosis, always somatization, and non-spinal problems. So let's talk about ankylosing spondylitis first. Ankylosing spondylitis is something you want to consider in very young people, less than the age of 40 and 30, not enough time to actually cause chronic spinal cord damage. Ankylosing spondylitis is an autoimmune condition, and basically, your normal spine should have a little curve to it to allow for flexibility. But with ankylosing spondylitis, you have loss of the actual areas in between it, and you get something called bamboo spine because it looks exactly like a bamboo, and so you have loss of the normal curvature, and you not only become shorter, but you get terrible back pain. The thing to consider about this is that it comes with some other symptoms as well. Uveitis is a very known other symptom of ankylosing spondylitis. And because ankylosing spondylitis is an inflammatory disease that has an autoimmune etiology, because similar to rheumatoid arthritis, it's going to present with morning stiffness that gets better with activity. The reason you can think about this is all these antigens and immunoglobulins in your body, if you move your body a bit more, they're going to circulate through your body diffusely, and you're going to have less pain in that aspect. Osteoarthritis is, again, an inflammation, but it's a chronic inflammation that develops over time. So you're going to see this in elderly people. What basically happens is rather than having a healthy spine, you have narrowed intervertebral discs because the bones degrade over time and become spurry, and they rub against each other. So this, opposite to rheumatoid arthritis and ankylosing spondylitis, gets a lot worse when you engage in activity because it's a physical problem. The other thing to consider are simple physical manifestations of your spine abnormality. You're supposed to have a straight spine, but you can have a curvy spine, scoliosis. This can be related to different disorders, but it can be idiopathic as well. And of course, aside from the actual spinal cord and bone, you also have a lot of organs in that area that can present as back pain too. So thinking through different problems, right? Like if you think about your pancreas, if you get inflammation in your pancreas, you get pancreatitis, and the classic symptom of acute pancreatitis is pain radiating to the back. So you can present as back pain. Likewise, if you rupture your aorta or have any sort of cardiac inflammation like pericarditis, you can have pain radiating to your back again. And of course, the classic kidney stones and renal infection can present as lower bilateral back pain as well. So that's something to keep on your differential. So whenever someone comes into your office presenting with back pain, you want to go through a very systematic way of how to figure out what's going on. So I know as a med student, we always learn the OPQRST rule. O, ask for onset. When did it start? P, how is it progressing? Is it getting better? Is it getting worse? What is changing? Q, for the quality. Is it stabbing in nature? Is it localized? Is it dull? Is it aching? Radiation. Is it radiating down your leg? Is it localized in that one spot? This is going to help you see if it's like nerve compression at all. Other symptoms associated with it. We talked about ankylosing spondylitis having uveitis, so definitely ask about that. And transforming factors. What's making it better? What's making it worse? Again, you want to rule out the big things, right? Constitutional symptoms, weight loss, fevers, night sweats. This is going to help you rule out, any abscess, any potential malignancy going on. Ask about a history of cancer, any neurological symptoms like numbness, tingling, bladder loss, incontinence. This is going to help you if there's any nerve impingement. And something I always like to ask is intravenous drug use. If they're a heavy drug user, you may see this in your patient population. This is going to seed way for Staph aureus and a lot of other bacteria to enter the bloodstream and eventually end up in the spinal cord and cause, osteomyelitis or a spinal abscess. So when we are talking about the physical exam, we want to be very thorough and very precise. The one thing we like to use is the IPASS rule. Inspection. So inspect the back. See if there's any masses or lesions. If you see shingles right away, you kind of have your etiology of back pain. Palpation. palpate their spine. If you see any point tenderness, you can kind of think about, vertebral fractures or paraspinal tenderness as well. Active range of motion. This is going to help you flex laterally or posterior or anteriorly on their spine, and it's going to help you assess their actual range of motion. Strength. That's going to help you see, if they're having any nerve problems, any weakness in your legs. And special tests. So another special test you can do is a straight leg raise test, and this can see any nerve impingement. Most consistent with sciatica, you're going to have back pain. In terms of labs, there's no labs that you can actually get for back pain unless you're thinking of malignancy. Then you can get any inflammatory markers to, increase your suspicion for this. I know we always think about back pain in terms of x-rays and imaging, but there's actually no indication to order it if you don't think you're going to investigate anything in particular. For instance, if your patient comes in with back pain and it's only 2 weeks of back pain and you're just thinking it's acute lumbosacral strain, if you were to get an x-ray, not only is it going to cause worsening radiation, but you're going to find, random things in even a healthy person that they're actually going to pursue further, work up, and it's going to cause unnecessary intervention. So don't order any imaging unless you need to. But if you need to, the MRI is the gold standard because it's going to look for the nerve problems like spinal infection, Cauda Equina, or any neurodeficits from a nerve impingement. If an MRI is contraindicated, you can get a CT. And the best thing to look for a malignancy is an x-ray because you're looking for the actual bones. Now, how do you treat this? The first thing is, for acute back pain, again, less than 6 weeks, most of it is self-resolving. So the main thing you're doing is reassurance. They can use heat, massage, and acupuncture, but really they should not alter their activity. You don't necessarily need to refer them to physical therapy and exercise at this time unless you think it's going to progress to a chronic disorder. So, you can do yoga, massage, things like that. But in terms of evidence for cold, lumbar supports, firm mattresses, and yoga, it's not very well established. So, you can tell them to continue or not. It doesn't really matter. Now, if a person's coming to you with back pain, they do want to treat it. So, usually it's an inflammation in their back. So you want to give them anti-inflammatory medications like NSAIDs. You can give them naproxen or ibuprofen at this dose for approximately 2 weeks. And hopefully this will help with the pain, but also the anti-inflammatory effects. Again, people jump to Tylenol, but it's for pain and not anti-inflammation. So you want to recommend an NSAID. But if you do give it, make sure you give it on a full stomach because it can cause GI upset and ulcers. Again, if you have a tight back, you're going to have muscle spasms, so you can give them muscle relaxants like cyclobenzaprine and tizanidine at the dose. And the thing to avoid in this is driving and working because it can cause some drowsiness. And again, if all of this fails, you can consider opioids, but there's actually no actual medical regimen known at this time. If it progresses to subacute and chronic, again, this is greater than 6 weeks and greater than 12 weeks, you need to keep your activity as tolerated because if you have back pain and you just sit on your butt, you're going to develop obesity, blood pressure, hyperlipidemia, all these things are going to go terribly. So you want to treat your back pain with heat and gentle stretching. You want to refer them to physical therapy and exercises because once they go to physical therapy, they can get the knowledge of how to do the exercises at home. But the main thing is not letting the back pain affect the rest of their life. Now, if they're still having back pain, it's still not working, you've tried the NSAIDs, back stretching, physical therapy, you can consider steroid injections. Steroids are anti-inflammatory, and so they do have short-term improvement, and it's usually used for the subacute and chronic areas. You usually trial this prior to surgery or for people who can't actually get surgery, and because it's anti-inflammatory, it's going to have the best effects for radiculopathy. You can also use local or trigger point injections, and these are basically more indicated in people who have actual point areas of tenderness where their back is like spazzing out. And it can provide months to weeks of pain relief. And essentially, you're either injecting saline or just stabbing them with a needle, and that's going to provide some pain relief. And again, finally, if all else fails, you can try like random things like botulinum toxin, which doesn't have too much of case report studies, but you can also refer them to surgery. And this is the last line of a family physician when they do refer out to someone. Hopefully you enjoyed the lecture and come back for more.